Hello everyone, this is Kelly Cox, and my presentation is on delirium versus dementia for our geriatric assessment. I have actually used this patient for our comprehensive assessment and polypharmacy assignment that we've had to do for this class. This patient has just been very interesting to me, and I hope you all will think so too. So the reason there are two diagnoses on my presentation is that I honestly cannot pinpoint one diagnosis to this patient at this moment. He is for further testing with a psychiatrist on board. He's a patient at the VA, and so they are doing some substantial testing for him to determine what the best diagnosis and treatment plan for him is at this time. So we'll go ahead and talk about the differences between delirium and dementia. Delirium, of course, we know is disturbance of cognition. It presents suddenly on those patients, commonly after an event, say a move or hospitalization or medical condition or even medication sometimes can do this to patients. It is pre-existing to dementia. Delirium is more prevalent in older adults. The statistic that our book shows us is 1.1% in those ages 55 and older. Medically ill, and the prevalence of delirium ranges from 10% to 30% of those that have been hospitalized, which this patient has been, and I will get into more detail about that here in just a second. Of course, dementia is the more scary diagnosis for this patient and his wife. You think of the Alzheimer's disease as the most common of dementia. Primary focus of this section will be on the dementia because honestly that's where his diagnosis is leading to with his past medical history. So this patient, why I've said the dementia is probably more prevalent, he has had cognitive changes in the past. He also has Parkinson's, so he is not medicated for that. But this disorientation that he's had and short-term memory impairment, he has had it before, but it has went away. And of course, he asked us to state statistics. About 1 out of every 8 65-year-olds or older have AD. So this is a very prevalent disease. And honestly, it's very sad because, the lack of research that we have, and our book even states that it is not 100% diagnosed until the autopsy, which I think is sad as well. So talking a little bit about our patient here that we're discussing today. He's a 71-year-old male patient of the VA. He is a veteran. This was our scheduled hospital follow-up after a UTI where he was hospitalized for a couple of days. Before the admission to the hospital, he presented at his residence, which he is in a nursing home called The Waters in Johnson City. He had a fever of 103, that's orally, confusion, and increasing incontinency of urine. He was originally treated in the emergency room with an IM injection of Rocephin. Of course, they did a culture on his urine. It did show Klebsiella, and he has had this in the past. He was treated with IV cefepime every 12 hours while he was hospitalized. He was discharged on the 16th and I think admitted on the 13th, so he was just there for 3 days. He did continue IV antibiotics at his residence of the Waters, and he had just finished 2 days prior for seeing me in the office on 10/24. Now, I looked at his labs from the hospital, and they had did a culture, when he was initially in the hospital, and they did one 2 or 3 days prior after his initiation of antibiotics, and the culture was clear, which I'm still kind of unsure of why they would do a culture on his urine as he's taking antibiotics, and I haven't really got a clear answer on that. I'm still trying to figure that out. His wife accompanied him in the office this day and says that she was still concerned because he was still confused and kind of talking out of his head is how she describes it. Says that he has done this in the past when they changed his Parkinson's medication. She said she couldn't remember what medicine that caused him to do this, but she was just very concerned. And I won't bore you all with the whole review of systems, just some pertinent positives. He was increasingly depressed. He had just moved to the Waters nursing home probably 3 months ago. Was a little bit more fatigued than normal, confusion, increased dysuria, and incontinency. The wife didn't really know if that was just he didn't really know what to do when he had to go to the bathroom or what that was. But both the patient and the wife were very concerned. Okay, no known allergies, no known drug allergies. His current medications are listed there on your screen. I won't read those off to you all. Over the counter, just Flonase. He is up to date on all immunizations, past medical history, Parkinson's, urinary incontinency, insomnia, depression, chronic back pain, hypertension, GERD, and enlarged prostate. His objective data, his vital signs looked good in the office when he was with us. Physical exam, nothing really to point out to. He just wasn't alert on the time or oriented on the time of day. Other than that, he knew the place, person, everything else. He was hard of hearing. He did have some pitting edema in his lower extremities. And the wife says when he does sit in the wheelchair for a long period of time, he does get like that. He also had a little rash where he'd been incontinent in his groin area. They actually had a diaper on him from his facility. Now, with the screening tools that we use, this is what really drew my interest to this patient. Talking to them in the office, he seemed totally with it, oriented, answering questions appropriately and everything like that. My preceptor actually suggested that we send him to the psychologist to have a cognitive screening, which is here on the left side of your screen. This was the most interesting thing that I've ever seen in my whole nursing career. And I know I don't have time to go over the whole thing with you, but just on the first box there, he was supposed to link the number with the letter and keep going. And you can see here he's kind of drawn something. He did not follow the instructions. We don't know if he didn't understand or what. In the second little box, he was supposed to copy that 3D box and then draw a clock. And he was supposed to write the numbers on the face of the clock. He really had troubles and struggling with this. I really, really felt sorry for him at this time. The other assessment that we used is a geriatric depression screening scale. He rated a 4 out of 15. The mini mental exam, and also listed on there was the global scale for primary degenerative dementia, and he did score a 3, which was mild cognitive impairment, which we were kind of expecting to see on that screening as well. So the plan with this patient, I actually went into the assessment with a psychologist with him. My preceptor allowed me to do that, and the patient agreed. She did her cognitive assessment and then is actually going to refer him to a cognitive impairment clinic, which he will actually go for an MRI of the brain and then go see a geriatric psychologist, and she will assess him further. Now, on our end, as the provider, we will repeat the urinalysis, do a BMP and a CBC to make sure that no infection is going on to cause his further confusion, make sure there's no electrolyte imbalances, and everything is all right medically for him. And of course, we will watch his cognitive impairment closely and educate the wife on this and things that she needs to call us about for us to see him quicker. And also, she was on board with him seeing Dr. Cook, which is a psychologist, for further recommendations of what we can do for him. The resources that this patient needs for safety would be a skilled nursing facility because his wife isn't able to care for him, which he is already in. They are making sure that he takes his medicine appropriately. is making sure he's clean, dry, fed, everything that he needs to be. So there's no issues there. The only issue is the patient is not happy at this facility. He would much rather be happy home. So actually, my provider is looking into getting him like an in-home care through the VA, because this patient is 100% service connected. He's a veteran, like I said, and so everything will be paid for through the VA. We are awaiting on the assessment from the psychologist, which, like I said, is Dr. Cook, and she further assessed him out to the cognition clinic, geriatric cognitive psychologist. And then we'll assess the patient's medicine. And I know I'm saying this because we just did that polypharmacy assignment, but there's a lot of medicines that could be causing some confusion. Seeing if there's anything new on his list or anything that's off whack that we need to adjust. And seeing how long he's been on this Parkinson's medication, because the wife did specify that this medicine, or a kind of medicine, she didn't know the name, had done this to him before, and one of the side effects of his Parkinson's medication is hallucinations. So we'll need to do some further research on that. So discussion, like I said, I kind of thought twice about putting this patient for this assessment, but he was very interesting, and I'm very anxious to see where he's going to go and what his official diagnosis is going to be. But talking about if they diagnose him with delirium from his recent hospitalization or dementia, we would want to talk to both the patient and the wife about treatment options and the next steps. If they wanted to add more medicines. There's some research that I found that they can treat the delirium with antipsychotic medications. Would the patient be willing, or would he benefit from those, or would it just cause adverse reactions that he did not want? In talking about the dementia, the research that I've done, I've seen that over 80% of the patients that were involved in the course of treatment with the diagnosis of dementia were apprehensive about starting medications, because they told them what the end result would be of this diagnosis. And like I said, it just depends on the stage of dementia and if you can cognitively appropriately have that conversation with your patient or not. And you would want to involve the family and kind of give them time to decide what they wanted to do and if the medication treatment would be appropriate for them. And honestly, the conclusion with this patient, he does have a diagnosis of Parkinson's. He is wheelchair bound. He has a lot of comorbidities to these disease processes that are not in his favor. And like I said, there will be further assessment and testing to properly diagnose this patient and to properly treat. But like I said, what we can do as his provider on his case is to ensure that there is no infection. His UTI is 100% cleared up. His electrolytes are in balance. His potassium and sodium, calcium, all that looks good. So that way we know that this is something else totally unrelated to the urinary tract infection that he had and was treated for in the hospital. And here is my references. I hope you all enjoyed this presentation. Thank you.